We're so thrilled to have you here today, Dr. Gerds.
Thanks so much, Dalton. It's a pleasure to be with all of you today.
So, and I want to actually highlight you. So participants, and I want to put a spotlight on you. So there, and then I'm gonna go ahead and do that. And just put the question side away since this is an open forum and I want people to be able to see you. I feel like that makes a little bit more sense right now. All right, so we're just gonna go ahead and jump in with some questions here. Um, First up, we have a question from Beth. Is MDS/MPN a form of blood cancer?
That is a great question. So MDS, MPNs, and then the MDS MPN overlaps, or MPN, MDS slash MPN. They are all forms of blood cancer, and that was recognized back in 2002 by the WHO. And this is largely as our knowledge about these diseases emerged, that mutations occur and drive uncontrolled growth of cells in the bone marrow, and that it's it used to be thought of as like a pre-leukemic state, but in of itself, though, as of 2002, was officially recognized as a cancer.
Okay. Do you have any insight on as to why so many people still seem to question if it is a type of cancer? Is it something patients are told at diagnosis or?
Yeah, I mean, even to this day, I feel like a lot of patients are not told it's a type of blood cancer, or even more accurately, a type of chronic leukemia. Again, the chronic means that people can live many years and not even know they have it. Acute being a very fast-moving illness, but these are all forms of chronic leukemia and are fact types of blood cancers. And I think it's rooted in I think a kindness, if you will, a desire just to kind of ease into it, be very soft about it, right? Like, oh, it's just a blood disease. You don't need to worry about it. Just to kind of lower the any type of anxiety that might be building up about it. But to me personally, I think my opinion is that at the end of the day, you got to call it what it is, right? If it is a blood cancer, even if it's a chronic disease with a long expected survival, you still need to call it what it is and get that information out there and have all the data on the table to have an honest and open discussion going forward.
That makes a lot of sense. All right. Next question up comes from Gerald. So Gerald has post PV myelofibrosis, currently a stage 3. He needs, so they have a hip joint that's completely shot, needs to be replaced. He wants an idea of how risky this procedure would be for them to have a blood clot, pulmonary embolism, stroke. So just for any sort of surgery, how do these conditions affect individuals that may need these surgeries?
Yeah. So we often talk about, PV and ET, polycythemia vera, essential thrombocythemia, as being, high risk for blood clots, especially in the perioperative period. And we often forget that myelofibrosis also carries some risk. A lot of patients with myelofibrosis, though, will have lower counts, particularly like lower platelet counts that might lessen said risk, but there still is some risk involved. And the risk is different for every given individual. I think there are some key things to look at. One is how well controlled the disease is. What are the counts actually doing at the time prior to the procedure? As well as what not just what the red cells or platelets are doing, but also the white blood cell count, because we know that across the spectrum of MPN, white blood cell count is associated with the increased risk of clot. I think there are other factors that need to be accounted for. What are the cardiovascular risk factors? Blood pressure, diabetes, those types of things that could also increase risk for blood clots. And then for the given procedure, in this case, an orthopedic procedure, what is the standard prophylaxis given for blood clots? Now, orthopedic procedures in particular are often accompanied by very aggressive anticoagulation postoperatively to prevent blood clots from happening, because we know that orthopedic surgeries are higher risk for blood clots postoperatively. So in general, we kind of advise making sure that the blood counts or disease is under good control prior to the procedure to minimize any risk. And then that post-procedure anticoagulation is used. Now, again, orthopedic procedures usually come along with a pretty significant amount of anticoagulation. You may not need to do more than what is typically done. But for other procedures that may not have a kind of a prescribed post-operative anticoagulation, you may consider using prophylactic blood thinners at that point.
Okay. And then next up from Patrick. I get severe cramps and spasms in my hands and legs and abdomen almost every day. What can I do? Can this be attributed to an MPN, or do you think that this could be something separate?
Yeah. So cramps, I have lots of patients that have this type of symptom say, hey, I'm having all these cramps. It's kind of unusual. I've seen it with patients who are not on ruxolitinib. I've seen it with patients who are on ruxolitinib or other JAK inhibitors. It's kind of hard to say, is it the disease or the medication or something completely unrelated, right? Because people who don't have MPNs can also have spasms and cramps. Usually with my patients, we start out with the basics, and that includes good electrolyte replacement. So we'll check magnesium and potassium, make sure those are okay. Even if the levels are normal, starting out with simple electrolyte drinks to make sure that the levels are adequate. Um, the other kind of key component to treating cramps is stretching, regular stretching, and exercise of those muscles. Those muscle groups can help prevent cramping, particularly at night. If you do stretching before you go to bed, can help prevent them at night. Beyond that, there are some other medications that can be prescribed to treat cramping. They include things like beta blockers and gabapentin, as well as some antispasmodics. But those do require prescriptions. But I think simple things, exercise, stretching in particular, the electrolyte drinks and replacements. Of course, there are the old wives' tales of pickle juice and mustard packets, and I have plenty of patients who swear by those things. They're certainly not harmful, and some may even find them tasty. But we kind of start out with the basics and work our way up. And if they're not getting better, do consider those prescription medications. If there's something else neurologically going on, or if it's an odd muscle group, I will refer patients to a neurologist just to make sure we're not missing a diagnosis otherwise.
Okay. And then next up, and I think this is one that a lot of people are going to be interested in, but I've been on Jakafi for the past 4 years. My hematocrit levels are remained under 42 with no side effects. My questions are the following. Is there a limit to how many years this medication should be taken? And if so, is it advisable to test another medication with Jakafi?
That's a great question. And this is specifically within the context of polycythemia vera. There is no kind of time limit for ruxolitinib in polycythemia vera. You would continue it as long as it's working. The original trials, the patients had very good hematocrit control multiple years out and are still on drug today. So there are people who are on the original studies that are still on it today and still doing very, very well. And I think that's a great thing. We don't want to necessarily have to use other agents or switch them out if we don't have to, and kind of hold those in reserve in case we need them. But there is no, as long as there's no significant side effects and it's doing a good job controlling the counts and symptoms and spleen size, we would keep it going as long as possible.
Okay. And next up, we have a question from Joseph. So Joseph was diagnosed with primary myelofibrosis pretty recently, about 3 months ago. His heme-onc has given him injections every week of Arincep, as well as taking medication called Vonjo. My hemoglobin is at a 9. My platelets are 69, just to give you an idea here. But they're having some dizziness. Doctors diagnosed him via bone marrow biopsy. He's 80 years old and unable to get a good bone marrow transplant. What do you think that sort of prognosis for an individual with some of these symptoms is? So if they're unable to get a transplant, do you think these medications are still pretty suitable for them?
Yeah, certainly, patients who have myelofibrosis, and we're thinking about the treatment for them, there's really a couple of directions we go and a couple of factors we kind of focus on in order to select the best treatment available. And, taking even a step back when thinking about prognosis, there are certain things that predict survival in patients with myelofibrosis, and we often look at major categories of things. So one major category would be, what are the blood counts doing? We know that anemia predicts for a worse survival, and thrombocytopenia as well. So if those are present in a given individual's disease, we know that those are high-risk features. Other high-risk features are in the category of genomics. Certain cytogenetic abnormalities, those are abnormalities in the chromosomes inside the myelofibrosis cells, can predict for a worse outcome, as can certain mutations that might be present in those myelofibrosis cells. Mutations like ASXL1, EZH2, or even TP53. So we often use these things called prognostic models, where all these different clinical factors and lab factors and values are all put together, and points are assigned to each of them. And then at the end, you get a total score, and a total score is associated with a risk category. And one example would be the MIP 70 score, that places patients in different risk groups. And so we can kind of get a sense of what the velocity of one's disease might be, and kind of give that information about expectations going forward. Now, when we think about the treatment, though, we really focus on the patient rather than what the risk score says. And we focus on a couple of different things. Does a person have an enlarged spleen and significant symptom burden? If they do, we want to use a JAK inhibitor to try to improve the symptoms and splenomegaly. The other kind of major vein of questioning is, well, what are the blood counts doing? Does a patient have anemia? And does that anemia need to be addressed? And so if a patient's having anemia, there are anemia supportive agents like Aranesp. Others include luspatercept, other ESAs, danazol, as well as momelotinib and pacritinib can all improve hemoglobin in patients with myelofibrosis. If a patient does have significant splenomegaly and symptoms, and we do need to use a JAK inhibitor, and the patient also has a lower platelet count, we think about pacritinib, or the brand name being Vonjo for that medication. So we think about pacritinib as an option because it can shrink spleens, improve symptoms, as well as increase hemoglobin, all within the context of a disease with low platelet counts. So those are platelet counts less than 50,000 typically, and also can, in some patients, be used in a platelet count less than 100,000. And we can combine some of these medications. So we often combine JAK inhibitors with anemia supportive agents. Again, the luspatercepts, the pacritinibs, or sorry, the luspatercepts and Aranesp and danazol. And so we'll use those combinations going forward to try to maximize both the spleen volume reduction, symptom burden improvement, as well as still try to treat the blood counts as effectively as you can. I think one major shortcoming of all the available therapies in considering this particular case is the thrombocytopenia. We don't have medications that can effectively and reliably improve platelet counts. And I think that's something that we're really looking to do, is modify disease and really try to change the course of what we see with thrombocytopenia.
Okay. And then, so this next individual, Peter, I'm actually going to combine their questions because I feel like they tie in pretty well together. So Peter writes, I think the yardsticks have moved over the years with the use of ruxolitinib. Um, what would what mean life expectancy would you be telling a patient who has early diagnosis, and is tolerating Rux well? And then they followed up with that of what advice would you give to a patient who's considering transplant, but are seeing good drug-based improvements, in particular, people who are more concerned with quote unquote lifespan as opposed to overall survival?
Yeah. I think that's the great question, a great question there. And I think it really brings up a couple of thoughts. The first of, how do we, again, determine prognosis? I rely heavily on the prognostic models. More recent prognostic models use more recent data, and I think it accurately reflects what the current standard of care is in terms of treatment and what those expectations for an overall outcome would be after that. Yeah, and ruxolitinib certainly has changed the world immensely for patients with myelofibrosis, and I would say as well as with PV and ET too. There's a really nice study that was published a few years ago showing that patients the average survival of patients diagnosed with myelofibrosis both before and after the FDA approval of ruxolitinib, and the curves are completely shifted. So yeah, your intuition serves you correct. Ruxolitinib really changed the face of the treatment of myelofibrosis and made patients' lives better. And then all the subsequent JAK inhibitors that have been approved, the three others, really have continued to push that line forward. In terms of what to expect on ruxolitinib, the comfort trials noted that a median duration of treatment of about 3.2 years. I think there are different groups of patients being treated with that can have different expectations with ruxolitinib. There's a group of patients who go on ruxolitinib and do well for very long periods of time, and there are some that it doesn't help them, right? And in fact, we often think about when should we try to switch therapy for these patients. And there's a really handy tool that I use in clinic and that others use in clinic called the RR6 model. It's the response to ruxolitinib at 6 month model is the full name of it. And basically, what it amounts to is if a patient is on ruxolitinib and their spleen is shrunk by 30% in volume, they are not getting regular transfusions or transfusion dependent, um, and are on the full dose of ruxolitinib, those patients do tremendously well for a long period of time. Every time you kind of uncheck one of those boxes, if you will, the curve starts to drop. And you certainly want to think about alternative therapies, other JAK inhibitors to maximize treatment, clinical trials, or transplantation for sure for those individuals who aren't hitting those three kind of parameters of a spleen volume reduction, being on full dose JAK inhibitor, as well as being transfusion independent. With considering transplant, there's kind of a rule of thumb that's easy to remember. If a predicted survival for any given patient is greater than 5 years, then non-transplant therapies tend to do better than transplant itself. If a predicted survival for a given individual is less than 5 years, then transplant then has the advantage when we look at all of our retrospective and prospective trials that have been done trying to answer that question. The same is true for myelofibrosis. It's true for related disorders like myelodysplastic syndromes and leukemias and the like. It really kind of tells us like about the function of transplant. But in short, if a predictive model or kind of your clinical suspicion suspects that a patient's going to live less than 5 years, then that's when to strongly consider transplantation.
Okay. And then next up is a really good, this is a pretty general one that I think a lot of people will be interested in. So people mention having additional bone marrow biopsies after an initial one. What is the indicator for an additional biopsy once the first one is confirmed in MPN? This
Yeah.
individual has ET, CALR1 confirmed via pathology. They take hydroxyurea. Is the need for an additional bone marrow biopsy based off of lab tests, symptoms, or time?
Yeah. So for my patients, I don't usually recommend like a bone marrow biopsy periodically just to have like a peek at the marrow. And it's really symptoms or clinically driven, if you will. So if there are blood counts we can't explain or change in the disease we can't explain, change in symptoms or splenomegaly that needs to be investigated further in relation with their disease, we'll do a bone marrow biopsy. But it's really clinically driven. The major advantage of diseases like MPNs is that we can easily check the disease via the blood. If we try to draw an analogy with, say, a lung cancer, it's somewhat difficult to go back in and re-biopsy that lung all the time. But with the blood, it comes from the bone marrow. It's a direct reflection of what's going on in the bone marrow. We can really infer quite a bit from the blood counts to what's going on in the bone marrow. And really, the bone marrow is really reserved for confirming our suspicion. If we suspect there's been a change in the disease and we need to confirm that with the bone marrow, we can then follow up with the bone marrow. But short of that, the blood counts are an excellent tool for monitoring the disease periodically.
All right. And then this one I'm going to tie to another one. So this individual asking, can CalR1 be a dominant with no symptoms? And then I also had someone send me a private message asking about if you had any take on the new Insight CalR1 phase one trial that just came out.
Oh, excellent. Um, what was the first question?
So they're asking about if CalR1 can be dominant, but they don't have any symptoms.
Oh, okay. Okay. Yeah. So within MPNs, we often talk about the driver mutation. So there are generally three driver mutations we talk about: JAK2, NPL, and calreticulin. Mutations in any of those three genes can lead to an MPN, myelofibrosis, PV, or ET, and kind of the root or kind of the central pathobiology of the disease. And even though they're different genes, they all cause the same thing downstream, which is constitutive activation or continuous activation of that JAK-STAT pathway. And that's why three different mutations can cause a similar looking disease. These mutations are generally and almost always mutually exclusive, meaning if you have a JAK2 mutation, you're unlikely to have a CalR or MPL mutation. And the reason we focus so much on these, not only because they are the kind of the central part of the pathobiology of the disease, is because we know that the different mutations tend to have different clinical features, if you will. We know that JAK2 disease is more likely to have blood clots than, say, a calreticulin mutated disease. And then they also provide different therapeutic targets. So calreticulin is kind of an oddball because it's external onto the cell. It's actually a protein that's stuck to the thrombopoietin receptor outside the cell, and we can develop therapies like monoclonal antibodies and bispecific antibodies and even CAR T cells and vaccines to try to attack the disease in a different way. That those types of therapies and those types of disease treatment approaches may not work as well with JAK2 or MPL mutated disease because it's not kind of amenable to the immune system getting to it. And so that's why there's a lot of interest in this monoclonal antibody against mutant calreticulin protein. Uh, and so far, the data looks really, really impressive. First and foremost, because of the lack of toxicity with this therapy, as we would expect with a monoclonal antibody. It's just a synthetic, fully humanized antibody that you would have, that looks like all the other antibodies you have in your body that have been developed by your immune system to help fight infections. So again, something that has a pretty minimal side effect profile. And we are seeing significant responses. There was a presentation at the EHA meeting as a late-breaking abstract detailing some of the early data from patients with ET treated with this monoclonal antibody. In this study, there is also a myelofibrosis arm. So patients with myelofibrosis are receiving this monoclonal antibody. That data is still maturing. It's a little bit behind in that kind of escalation process as it's being developed. There's also an ex-US trial that's ongoing that includes patients who are on ruxolitinib. So it's looking at the combinations of ruxolitinib and this monoclonal antibody. So I think as we go over the next 12 to 18 months, we're going to get a lot more information from these two very important clinical trials that will help give us a good sense of, is this a not only rationally designed type of treatment, but is it really kind of panning out, and are we seeing durable and meaningful clinical responses?
And then next up, so this comes from Phil. So Phil has previously been on Jakafi, as well as a study drug, and he became refractory to both prior treatments. But Ojara seems to have success as a salvage therapy. But they're wondering, is this really a false sense of security with respect to trying to decide if they want a hematopoietic stem cell transplant?
Yeah.
So kind of weighing that option.
Yeah, I think, for a given individual who's already had a JAK inhibitor, is maybe on their second JAK inhibitor, that's a great question. I think, in the days where all we had was ruxolitinib, if ruxolitinib wasn't working, then transplant was an obvious answer. It might be a little bit tougher now since we do have very good JAK inhibitors that might work when ruxolitinib is not working. Momelotinib being one example. But I would kind of go back to first principles and kind of say, well, in with that given individual's disease, do we expect them to live 5 years or greater without the transplant? And if there are other features there, not just Jakafi not working, but are there other features that suggest a shortened predicted course of disease? I would still consider transplant if that is an option. No, I would certainly use a JAK inhibitor in parallel, whether it's momelotinib or another JAK inhibitor, because we know that JAK inhibitors before transplant improve post-transplant outcomes. But I still think the question is transplant or not. And then after that, what else do we do in the meantime or instead of transplant? Because again, transplant is the only therapy available today that has curative potential. And so I think really kind of anchoring the decision process around that yes or no question is kind of the place to start. And then after that, selecting the best path forward that aligns with the goals of the individual regarding that.
And then next up, this comes from Graham, who's actually watching us on YouTube. So they ask, could ruxolitinib slash Pegasus combination of myelofibrosis cause acute abdominal pain?
Yeah, so acute abdominal pain can happen for a lot of reasons. I think, with any clinical trial or treatment, you really got to kind of use your detective skills to say, well, this is or isn't related to the treatment, or it is or isn't related to the disease, or some third process or third factor even. And I think, for an individual, it's kind of tough to say. I would not expect necessarily the combination of ruxolitinib and Pegasus to cause acute abdominal pain by itself. That would be an unexpected side effect for that combination. Now, I also want to point out that that combination isn't not widely used outside of clinical trials. There are some clinical trials that have looked at this combination, but typically, I think if we look at things like the NCCN guidelines or ELN guidelines, it really recommends one or the other for given situations. And so I would say that this is kind of difficult to say. There isn't a lot of data with the combination. There are a few clinical trials that have been done and a few ongoing studies. But given the mechanism of action of the drugs and the known side effect profile, I would not expect it to cause acute abdominal pain.
Okay. And then they also had another question of, do MDM2 inhibitors have an impact on TP53 mutation?
Yeah, so MDM2 inhibitors, just to give a little explanation. So MDM2 is often overexpressed in MPN cells relative to normal bone marrow cells. MDM2 is an inhibitor of P53. So if you inhibit the inhibitor of P53, you can allow P53 to go do its job, which is called apoptosis or cell suicide. And what you effectively have at that point are myelofibrosis cells or PV cells or ET cells dying off in the presence of this medication, which is a pretty desirable effect. And it's been shown both in preclinical models that inhibiting MTM2 inhibitor can have a profound effect at cleaning out disease, as well as in clinical trials. There have been trials with older versions of MDM2 inhibitors like idesanutlin that have shown long responses in patients with polycythemia vera. And there are ongoing studies with a drug called navtemadlin, which is a newer, perhaps better MDM2 inhibitor that's being studied as of right now. So certainly an important pathway in the biology of MPNs and a very targetable pathway and a pathway that's being actively investigated with modern therapies and current therapies. P53 mutation. So MDM2 inhibitors typically do not work in the presence of an TP53 mutation because you have to have that native wild type functional TP53 in order for the drug to really work. There is some debate on whether or not MDM2 inhibitors can promote the growth of a subclone that contains a P53 mutation. We do see that there are small TP53 mutations that can be present. This is data from the navtemadlin trials showing that there might be a little bit there below our typical level of detection. It doesn't appear to see that they kind of grow out, but I think more follow-up from these navtemadlin trials are going to be needed to really answer that question fully.
Okay. And then next up, this is one that I see all the time. And they're asking about supplements. So this individual has myelofibrosis, and they're wanting to see if there's any sort of supplement that they can take to increase immune system support. They're already doing some sleep nutrition and spiritual meditation, but they just want to see, are there any supplements that are safe for myelofibrosis when not on medication?
Yeah, I think that's a great question, a question I certainly get all the time. Ranging from what should I be doing on my own for myelofibrosis or my MPN or down to specific type of supplements. And I would say in general, it's tough to say. There are not a lot of good rigorous trials with supplements for myelofibrosis or any MPN for that matter. There have been some pilot studies that have been done with various supplements, even some preclinical data that exists out there, such as N-acetylcysteine, for example. Um, but those good kind of rigorous prospective trials that will help us answer the question, does supplement X, glutathione, N-acetylcysteine, does it actually make patients live better or live longer? That data is lacking. In general, most of these supplements are safe. And the approach I take with my patient is just let me know what you're interested in trying, and we'll take a look at it and see, make sure it's not known to be harmful. If it's known to be harmful, obviously we want to avoid it. If it's not known to be harmful or we don't anticipate any major interactions or side effects, give it a try. Give it a month, 2 months. If it's achieving the goals that we set out for, is it making you feel better? Is it controlling some sort of symptom? Then great, we'll keep it going. If it doesn't, then we move on to something else. So you really have to kind of take a singular approach with these because there aren't large data that exist. Um, For other things, I do recommend there are good data for regular exercise. And there is even some data that suggests that some exercise can actually make people's symptoms better. Some patients who are suffering from symptoms from their MPN. A good, well-balanced diet is always a good idea, no matter what we're talking about, because it's good for your overall health and well-being. There actually are some data that suggest that a Mediterranean diet may have certain advantages within MPNs, particularly with its focus on reducing inflammation, and cardiovascular well-being. So if anything, that would be something I would certainly consider. But common sense is common sense stuff for a reason because it's proven over time. So a good attention to a diet and exercise are always very important in the overall care plan. And with respect to giving us individual supplements, I advise taking it on a one-on-one basis with your doctor, saying, "Hey, this is the supplement I'm interested in. Let's make sure it's safe and give it a try in a very controlled manner."
Okay. And then next up, we have someone saying, my platelets are low and I have had two severe nosebleeds requiring ER trips. Is there anything that I can do? So this individual has myelofibrosis and they do take Jakafi.
Yeah. So I have a couple of thoughts there with that. Certainly nosebleeds can happen. Nosebleeds happen for one of two reasons. One is the blood isn't clotting properly or there's something structural, right? So the first thing is the structural. Is there a vessel that needs to be cauterized? Are the mucous membranes inside the nose being taken care of? Do you need like nasal saline to keep them hydrated or an ointment at night to keep them hydrated? So certainly starting with those concerns. And once those have been ruled out, then you kind of pivot towards the disease. And certainly patients with low platelet counts can have nosebleeds just because the sheer quantity of platelets are low, as well as the quality of platelets. We all know that patients with MPNs have intrinsic platelet defects and can, even though their platelets may be normal number, they may be prone to bruising and bleeding. Lastly, are there drugs that are making the platelets work less effectively? So aspirin would be a prime example. And that's a desired side effect for patients who have PV and ET. We want the platelets to be a little less effective at clotting, but in someone who already has a low platelet count and having nosebleeds, that we may not want that. We may want to back off that aspirin if a patient's taking aspirin. Ruxolitinib can lower platelet count numbers. And so in someone who is having a bleeding complication on ruxolitinib or any JAK inhibitor, we may want to back off the dose there. I think for the more acute kind of treatment, so if a patient is having a nosebleed, there are some things that we recommend. Afrin is one of those things. It can cause the blood vessels in the nose to constrict, thus help treating an acute bleed. Now, that's not a long-term fix, though. You have to kind of get back to say, well, what are the different risk factors leading to those nosebleeds? Is there something structural? Is there something medication we need to adjust, or otherwise? But that can be kind of a short stopgap if you're stopgap if you will, short-term stopgap if you will, in order to keep you out of the emergency room for that nosebleed. But really, you want to make sure there's no structural issues that a vessel does not to be cauterized. And then what are the things that could potentially be lowering the platelets or making the platelets less effective and trying to address those.
And then next up, so this individual is just asking if you talk a little bit more about allele load with CALR and the ranges of allele load or allele burden.
Yeah. So allele burden is simply just the amount of abnormal to normal reads. And it's a percentage. So if I say that, the allele burden is 25% for a given mutation, it indicates when that test was run on that sample, 25% of the times that they looked at that particular gene, it was abnormal, and 75% of the time it was normal. So allele burden we kind of use that as an approximation for the amount of disease. We think it's relatively accurate for that. I mean, there's going to be some intertest variability depending on the platform, the location, the sample, where the sample's from, is it blood or bone marrow? So there will be some variability there, but it's a pretty good way, an easy way of measuring amounts of disease. Allele burden can range anything from 0 to 100%. That's the range. And patients at different times in their disease, different amounts of disease in their body will have different allele burdens. And we do really look at this for a couple of different reasons. One is there are associations, particularly with JAK2 mutations, between allele burden and clot risk, or allele burden and other outcomes such as disease progression. In treatment, we sometimes want to see allele burden going down. The kind of the poster child for that are interferons, where in some patients we put them on interferons, particularly patients with ET or PV, and over time we can see those allele burdens going down. And that suggests a deeper or greater response to that treatment and potentially a long-term benefit. And of course, in a lot of our clinical trials, we check that as a surrogate for disease modification. Are we driving the amount of measurable disease down via this test? With, of course, the caveats that I mentioned earlier, that it's not a perfect test, but a pretty good one that we can use to make those scientific inferences when we're doing trials.
Okay. And then this one, I apologize because I'm sure I'm going to say a word wrong here, but it's something that's really interesting. So, why does no one ask about erythromelalgia in the skin to areas under clothing but in the sun? Looks like livedo reticulars, but feels like your blood is boiling, even a cool spring morning. If the sun is out and I'm sitting on in dark pants, my thighs are on fire. It was one of my most distressing symptoms. I don't know why it was happening, and the doctor at the time didn't have any ideas. I found out that this happens to quite a few of us. Is this a known symptom um, for MPN patients, or is this something else potentially going on here?
So, I believe erythromyalgia. So it can be a symptom of an MPN. We often think about it, I guess, more in the context of a polycythemia vera, but certainly can occur with any of the MPNs. And in general, once the counts are under control, and in particular when we're using JAK inhibitors, those symptoms can get better. It's kind of an unusual symptom, I think, in general for things, right? There's not a kind of a long line of patients with erythromyalgia knocking down their primary care door's office, trying to figure out what is this. So it's kind of an unusual thing, I think, in the context of just general medical care, but can be seen in patients with MPNs. And probably not. I think another challenging factor is the fact that not everyone's erythromyalgia is exactly the same, right? Your erythromyalgia did not read the textbook before going to see the doctor to say, oh, this is
Mhm.
exactly what I should be like. And it might be a little bit different. We see that with lots of symptoms that we are associated with MPNs. They're not quite textbook because, again, your disease, your symptoms don't read the textbook before you go to see the doctor. And so you got to kind of use a little bit of art there to kind of put things together. Now, you know, I think the other challenge with a lot of these things was we look back with hindsight. Um, a symptom may have been present for some time and it just didn't really make sense and maybe, it didn't fit with other pieces, but as more information came along, ultimately made the diagnosis of an MPN. Then you look back and say, well, gee, this may have been happening for some time just
Mhm.
because the symptoms may be kind of oddball or subtle or singular even for a bit, and you may not arrive at that conclusion. Medicine is a lot like detective work. You got to take bits of information that you have and kind of come up with a suspect list and work through those suspect lists often. And if there's not a lot of clues there, sometimes the cases are hard to crack and may take a long time. So, certainly that is part of it and makes it a little bit more difficult, I think, to relate something like erythromyalgia to a diagnosis of an MPN.
Okay. And then next up, this individual's asking, so they're interested in stem cell transplant, as many individuals are, but they have a history of Budd Chiari. So they're 67 and they had Budd Chiari a couple years ago. Um, they were recently told that they would not be a candidate for transplant. Do you think it's worth it for them to seek a second opinion on that?
Yeah. So kind of 2 points there. One, Budd Chiari is it's something that can happen as a result of the MPN, particularly those with JAK2 driven disease. We see Budd Chiari. Budd Chiari is a pretty devastating type of clot because it can lead to liver failure. And within respects to transplant, since so many medications are metabolized in the liver, the medications that make transplant possible are metabolized in liver, as well as a common complication after liver or after bone marrow or stem cell transplant is a liver complication, like VOD or SOS or just chronic graft-versus-host disease of the liver. So there can be liver complications post-transplant. We know that patients who have significant liver dysfunction going into a stem cell transplant are at incredibly high risk for complications afterwards and a shortened survival. So for patients who are considering transplant, we do want to check all those other organs, lungs, heart, and even liver. And if there's a lot of organ dysfunction or dysfunction within one organ, it may increase the risk of complication for transplant to the point where it's just really, really dangerous. So really they have to take a close look at what the liver is doing and say, is it healthy enough to withstand a stem cell transplant? And then the second part of the question about second opinions, I fully and 100% support second opinions. That is never a wrong answer, seeking a second opinion. Um, Worst case scenario with a second opinion, you go see another person, they say the exact same thing that the first doctor told you, and you get that reassurance that you're on the right path with that second set of eyes. Sometimes that second set of eyes has a slightly different perspective and may have more options or a different opinion on how to go about things. And I think that's good to consider. Sometimes that then warrants a third opinion, but that's okay too. Get that information. There have been so many times throughout history where a second opinion may have changed the course of history. I'm here in Cleveland. We have our own kind of presidential history, if you will, with James Garfield. And so the short story there was James Garfield there was an assassination attempt. He was shot. And it wasn't the assassin's bullet that initially did the damage and ultimately led to his death. It was the fact that the bullet was there, but the doctor who was taking care of him really wanted to get that bullet out. And over the course of several months, kept going back in, trying to pull this bullet out instead of just leaving it there. And there were doctors in the orbit who said, maybe we should just leave it there. There's this whole concept about sepsis and bacteria, and maybe we're just putting more bacteria in there as opposed to just let it be, let the body heal. And ultimately, he did succumb to sepsis, which the opinion is that it was because of re-entry into that wound. So if the second opinions were invited and validated, maybe James Garfield did not succumb to that event and would have lived on throughout his whole presidency. But so I think that's just one example of why a second opinion can be important. There may be a different point of view that may ultimately be better. So always agree with a second appointment. Worst case scenario, you'll get just kind of reassurance that you're on the right path. Best case scenario or an alternate scenario, you might get some additional information that sets you down on a better course.
Okay, then this is a really good one. So why are cardiology screenings not encouraged if so many MPN patients have pulmonary hypertension? Um, this is a JAK2, often a JAK2 related disease. So do you think cardiology screening should be recommended?
Oh, that's a really good question. So cardiology screening, you kind of taking a step even further back. There's an entity called CHIP, which is clonal hematopoiesis of indeterminate potential. It's kind of like a mutation's there, but there's not disease. So we can detect JAK2 mutations as part of CHIP. In fact, it's probably about the fifth most common CHIP mutation. And in those patients, we do know that their cardiovascular risk is higher. So and at least at our center, if we identify a patient who has a CHIP mutation, a JAK2 CHIP mutation, we send them to preventative cardiology. So the preventative cardiologist here screen their cholesterol, do echocardiograms if necessary, and EKGs and all that workup. So it's an important part of the care with a patient with CHIP. And if we say, well, gee, if that's present in a patient who just has the mutation and not overt disease, it's probably got to be even more pressing for a person who has overt disease. So I think it's worth it. Usually with my patients, we'll talk about it, right? Do you have a cardiologist that's kind of looking at your blood pressure, cholesterol, echocardiogram, EKG kind of stuff, or a primary care doc that's doing the same, and really kind of making that part of the whole part of the treatment plan. If a patient doesn't, I'll refer them either over to preventive cardiology or have them circle back with their primary care doctor to get that stuff taken care of. In terms of echoes for everyone to screen for pulmonary artery hypertension, certainly that's a thought, right? Should we just do echocardiograms in all patients with MPNs, particularly those with myelofibrosis, because there is an increased risk for pulmonary artery hypertension. Pulmonary artery hypertension is high blood pressure on the other side of the heart, the right-sided circulatory system. So the left side of the heart, it's the part that pumps out towards the body and then back to the lungs again, back to the heart again. The right side is pumps to the lungs to get oxygenated before it comes back to the heart to get pumped out to the body. So we can see elevated right-sided pressures in patients with MPNs. A screening tool for that is an echocardiogram to estimate those pressures. The current practice recommendation is to screen people for symptoms related to pulmonary artery hypertension, because that would then trigger treatment. You can have pulmonary artery hypertension, but not necessarily need treatment as long as you're asymptomatic and the disease is minimal. And so in patients that I have who have an MPN, who have shortness of breath, have swelling in the legs, kind of the constellation of symptoms that suggest pulmonary artery hypertension, I do get an echocardiogram. And then if identified as a potential elevated right-sided pressures, I will work with our pulmonologists here who specialize in pulmonary artery hypertension to get further testing or start treatment for that.
All right. And then, so this one, I'm just going to go ahead and read it. So this individual found a recent study where there is some sort of cell shedding in MPN patients that they had never heard of, which turned up to be causing clots and actual holes in the glomeruli of the kidneys. An MPN researcher found this via studies because they noticed that it was difficult to start and complete studies because 80% of MPN patients have at least stage one renal disease. Do you think that this cell shedding could be part of the reason that people with myelofibrosis and low count still get clots elsewhere? Could this be a risk in symptoms when they do not disappear when counts are controlled?
Mhm, mhm. Yeah, so I think a couple of interesting points there. I think at the end of the day, clot risk, I think it's poorly understood overall why patients with MPNs have clots, or why patients with JAK2 mutations have clots specifically. There's been lots of studies that have come along and suggested different mechanisms of action. There's certainly a lot of studies that have looked at adhesion molecules of white blood cells. There was a very kind of somewhat famous study that basically dissected out the cells that line blood vessels and found JAK2 mutations in those in people who had blood mutations, and those are completely different cells. So why would that happen? Kind of interesting. Um, there's been looks at microparticles from platelets, lots of different types of things. But the challenge is trying to put it all together in a A plus B causes C type of
Mhm.
fashion. And probably at the end of the day, what my suspicion is that there's lots of different things that are influencing why people clot who have MPNs. And it's probably not just one of these things, it's probably all of them. And which is going to make it very difficult to treat too. Because if there are multiple factors that lead to an event, you have to address all the factors. And so it probably makes more sense actually kind of getting back and treating the underlying disease altogether, as opposed to treating this intermediary step. Um, so again, at the end of the day, I think we're still trying to figure out exactly why there's an increased clot risk for patients with MPNs. Certainly this could be part of the story. But at the end of the day, I think the most important thing is just is really treating more effectively the underlying disease, because then that will make that risk go away.
Okay. And we have just a couple of questions left here. So this individual is asking, can fainting be a symptom of post-ET myelofibrosis?
Good question. So fainting. Fainting can happen for different reasons. In general, fainting or lightheadedness, where you stand up and the shades are kind of coming down and you pass out, uh, really is a result of not enough blood getting to your brain. Um, and the kind of the classic example is low blood pressure. So if you're on a lot of blood pressure medicines and you stand up and you just can't generate enough force of the blood to get to your brain, you can pass out. Vasovagal response is another way you can pass out. That's the kind of like you're in the Christmas pageant in the back row, and all of a sudden halfway through the song you kind of collapse because all the blood vessels really kind of relax. There are two things that get blood to your brain. One is the fluid. You have to have a squeeze, and you have to have enough stuff to squeeze, right? So if you don't have enough volume of blood and plasma to you could pass out when standing up or faint. And if your blood vessels don't all contract to push that up there, you could also pass out or faint or feel lightheaded. And so we really start to think about, passing out or lightheadedness or fainting in those kind of spectrums. Is it a volume issue? Is it a blood vessel needs to contract issue? In general, there are things that are kind of peripherally related to myelofibrosis that may lead to that. But myelofibrosis itself, I would say, doesn't commonly cause fainting. So in an individual who has a fainting episode, I would start to ask myself, well, is it a blood vessel constriction issue? Is it a blood volume issue? And try to work through that to try to get the answer.
Okay. And then this is probably going to end up being our last question. So this individual said that they had a scan for diverticulosis and they found splenomegaly. Blood and marrow test showed anemia, and they had an endoscopy which showed a gastric hemorrhage. Can healing the hemorrhage eliminate the anemia and reduce the spleen? And will it help their fatigue symptoms go away?
Yeah. So in MPNs, fatigue is it's a tough one. So it's definitely the most common symptom. It's the most severe symptom for patients. And conversely, it's the most difficult symptom to treat. And I think this is for a lot of different reasons. But the biggest one being that fatigue is multifactorial. There are so many things that can cause fatigue in one given individual, and it's often additive. Again, medications, sleep hygiene, sleep apnea, the disease itself, the medications used to treat the MPN, it can all cause fatigue. And for any one person, it's probably a combination thereof. And so fatigue is tough. Now, if someone's anemic and severely anemic, that certainly can cause fatigue. And if you reverse that anemia, they can feel a lot better. So if someone's hemoglobin is 6 or 7, or even periodically dipping down to that level, and you can say they have an ulcer, you fix the ulcer, and that hemoglobin then consistently is higher, I'd expect that person's fatigue to get better in part. There are data in MPNs that do suggest fixing anemia can improve fatigue. But it may not get the fatigue all the way down to zero. And so then you got to look for other reasons why an individual may have fatigue. What's the sleep hygiene look like? Are there risk factors to sleep apnea? Are they on other medications we know that cause fatigue, like blood pressure medicines, for example? And certainly, truly, piece by piece, try to peel away at that fatigue. But it's a challenge, admittedly, and a challenge to the point where if you look at clinical trials that are done in the MPN space, a lot of times fatigue is thrown out as a symptom just because it doesn't always track with other symptoms, with spleen response, because it is so difficult in its nature and so multifactorial in its nature.
Okay. Yeah, I know fatigue's a question that I see all the time. The community is always wondering about it. So thank you for covering that one. But all right, I think we are running short on time here. So we'll go ahead and wrap up there. But thank you again, Dr. Gerds. That was so wonderful of you to do that and to spend your last hour answering questions for us.
My pleasure.
I'm It was incredibly helpful. So thank you. All right. And then I just wanted to let everyone know about a couple of upcoming events that we have. So on this Wednesday, we have Coping with Blood Cancer Uncertainty, Practical Tools to Manage Stress and Anxiety. This will be with the psychiatrist. So should be a really good one to tune into. And then on July 2nd, I have Fighting Chronic Cancer with Ruth Bain Ravel. So Ruth is actually a myelofibrosis patient who previously has lived with ET at some point and PV at another point. So offers a really good perspective. She's lived with an MPN for over 2 decades, so should have some really good insights for that one. And then finally, on July 23rd, we have primary versus secondary myelofibrosis, similarities and differences. This will be with Dr. Anand Patel. So the link to sign up for any of these can be found on the HealthTree website, and I hope to see you guys there because I think they'll all be really good events. And finally, before we wrap up, I want to say a big thank you to everyone for being part of this community. It really does matter to us that you take time out of your day to join us for these events. Big thank you to Dr. Gerds again for joining us. We wouldn't be able to do these types of events without specialists like yourself. So truly thank you. And your support from everyone means so much to us. I've gone ahead and I've included my email address on this slide. Please don't hesitate to reach out to me about anything. If you just want help finding resources or you have a question or you just want someone to talk to, I'm always available to members of the community. So please do not hesitate to reach out. I want to remind everyone again as we leave that you do have that survey available. It does really help when I'm trying to come up with new topics for events. So if you would take a moment to fill that out, please go ahead and do so. I do really appreciate it. And then I am going to turn off the live stream and the recording, but I'll stay on for a couple of moments if anyone wants to ask me any questions or speak with any members from the community. I really just want this time to be for us to come together and get to know one another and just really have that sense of community. So if you need to go, totally understandable. But if you would like to stay on and chat, I will be doing that for a couple of moments. So yeah, I'll go ahead and turn the live stream off now if I can find the button. Stop share.